Thank you, Mr. Chairman. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It's my honor and pleasure to be here with you. Thank you, Dr. Am, for kind invitation and the organizing committee. I will start to talk a few words in Arabic because they are emotional. Then I will continue my lecture in English. أنا مصري واتولدت في مصر سنة 1985 وبعدين جيت البحرين سنة 1986 مع والدي ووالدتي. وقعدت في البحرين لحد سنة 2001 فأنا تقريبا أكتر من 18 سنة قضيتها في عمري في البحرين. كنت في الابتدائي في مصر في مدرسة جابر بن حيان لسه فاكرها لحد دلوقتي، وفي الإعدادي كنت في مدرسة القضيبية، وفي الثانوي كنت في مدرسة الشيخ عبد العزيز، والحمد لله ربنا أكرمني وطلعت من العشرة الأوائل، ورحمة الله على الشيخ خليفة كان يعني كرمني وسلمني شهادة يدا بيد. أشهد الله إن أنا ما شفتش أي حاجة وحشة في هذه البلد. فكل التحية لإخواتي وبلدي التاني البحرين اللي بتشرف إن أنا أكون في وسطهم يعني. Thank you, Dr. Am, for inviting me here to be with you. Thank you, Dr. Ahmed, for always supporting the collaboration between the endocrinologist and radiologist. I'm from Egypt. This is the ancient Egypt by AI. I'm from Mansoura, which is about 70 kilometers to the north of Cairo. This is my city. It is the pride of the Delta. I invite you all to come and join us in Mansoura. This is my university. I'm associate professor of medicine and endocrinology in Mansoura University, and this is my hospital in which I affiliated. Before I start, this is my disclosure. I don't have any conflict of interest for this lecture. Let's go to work. My lecture is about the non-surgical innovations in the parathyroid management. All of us are clinicians, and let's hit the presentation by this real case from my clinic. This lady is a 53 years old lady. She's a postmenopausal 5 years. She is taking care of her health. She's always annually doing her annual screening, metabolic screening. And this time one of her doctors advised her to do DEXA scan as a screening for the osteoporosis. And she discovered that she is having osteoporosis. The past history and the family history and the medical history and the drug history and the special habits, all of them are irrelevant. So most probably we are excluding any apparent secondary cause. But we should do some laboratory investigations. One of those are the calcium profile and the parathyroid, and here we notice that we found a hyperparathyroidism with a hypercalcemia and the hypophosphatemia in relation with a normal vitamin D. So this is a classic case of primary hyperparathyroidism. After we discover and we diagnose the hyperparathyroidism laboratory, always in endocrinology, in most of the disease, the lab is first, then the radiology. So after the lab is confirming that this is a case of a primary hyperparathyroidism, I did for the patient the ultrasound. If you notice and see here in the ultrasound, let me check for the pointers. If you notice here in the ultrasound, this is the thyroid parenchyma. This is the solid hypochoric lesion, which is measuring about 1 centimeter in the maximum diameter. This is maybe the parathyroid. This is maybe thyroid nodule, which is a thyroid nodule. Maybe this is both of them. One of the characteristic things that we learn from our colleagues in the radiology that want to be anatomical location, and the parathyroid is characterized by having a polar artery, which is an artery coming from usually the inferior or the superior pole of the parathyroid mass. Mostly it is a case of parathyroid adenoma located on the left side, but also we should confirm this by doing parathyroid washout. Usually if the mass is less than 1.5 centimeter, usually the systemic technetium scan will not give you satisfactory results, especially in a mild cases of hyperparathyroidism. So you can rely on it, but if it is negative, usually it makes you false negative reduction in the localization. So we depend on the parathyroid washout, in which we estimate by the ultrasound guided aspiration of this mass and send it to the lab to measure the parathyroid. And as you notice here, it is more than 5,000. If your clinical pathologist is not familiar with this test, usually he will be agonized from this test because he will find thousands and thousands levels of the parathyroid. So you should notice him that this is not a serum parathyroid. This is the parathyroid wash out from inside the mass. Also, to rule out the medullary thyroid carcinoma, we usually do the serum calcitonin, and it was negative. When you look to the guidelines, this patient should be treated. And the best treatment is the surgery, especially if the patient is having young age, less than the 50, having osteoporosis, or having stones, or having hypercalcemia more than 1 milligram above the upper level normal of your lab, and the patient is having no contraindication for surgery. So this is the best case of surgery. But we have now another options we should discuss with the patient. But the message that this patient should be treated, and usually the medical treatment is not satisfactory. You should do some intervention for this case. Before I start for the intervention, usually in the medical school, and we used to teach our medical students that the parathyroid is stones and bones and moans and groans. Only the problem is the musculoskeletal system and the kidney and so on. But nowadays, the hyperparathyroidism is classified as an independent cardiovascular risk factors. Those patients with a hyperparathyroidism is having cardiovascular risk factors, especially if your patient is already having heart failure or chronic kidney disease, or having, for example, type 2 diabetes and so on. So please don't just rely on the parathyroid that the morbidity is only on the bones. One will say, I'll just give the patient bisphosphonate and the osteoporosis measurement. Especially if the patient is having another cardiovascular risk, this is confirmed by a lot of studies and a lot of meta-analyses that it is increase the morbidity from the cardiovascular disease. What is the option? We have the classic, standard, irreversible option, curative option, which is the surgery, and no one doubt about the surgery. But nowadays, as Dr. Ahmed said, that we have another options from the interventions to trying to minimize the hospitalization and minimize the surgery and decrease the morbidity and hospitalization period. The thyroid is easy, because if you're just doing simple hydrodissection, the problem will be saved and the temperature will not be reaching surrounding structures. If the nodule itself is having a healthy thyroid tissue, you may sometimes not doing a hydrodissection. But in the parathyroid, it's a very critical, very critical position. Because if you look here, this is the parathyroid. If you look here, the parathyroid, the superior parathyroid, is very close to the recurrent laryngeal nerve, very close to the trachea and the esophagus. And the same also for the lower parathyroid. So 100%, if you are entering by the antenna and doing ablation, 100% or near 100%, you are doing injury for the recurrent laryngeal nerve or trachea. So the main difficulty in doing parathyroid ablation is to isolate it by the hydrodissection from the surrounding structure. Because if you do parathyroid without hydrodissection, near than 100%, you will be complicated by injury of the trachea or injury of the recurrent laryngeal nerve. So how we do it? Simply, the most expensive part is this, is the antenna of the microwave or the needle of the RFA. Other things are outpatients, are easy, are just disinfectant and sterile gloves and just the fluids and local anesthesia. And of course, the ultrasound. Usually, we assess the vascularity here. We assess and measure the parathyroid, and this is the live Doppler here, as you see. This is the mass, and this is the Doppler, and this is the vascularity, and this is very important to assess, because the first sign of successful parathyroid ablation is disappearance of this vascularity. If this vascularity do not disappear, usually the recurrence rate or the failure rate is very high. So after we assess the vascularity and we save it before the ablation to make it as a reference point or reference video, we just simply do it by local anesthesia. This is the needle of the local anesthesia. All of us know that the thyroid and parathyroid tissue themselves do not have nerve ending. They don't sense the pain. The pain is only coming from the skin, the strap muscles, and the surrounding structures in the thyroid and the parathyroid. So the most important thing is to do anesthesia, then trying to make the parathyroid as an island surrounded by fluid. Usually, I use a system here by putting the needle above and below the parathyroid, trying to make it isolated with a continuous pushing of the fluid. As you see here, I'm coming here, I'm doing hydrosection from the intromedial, trying to separate the parathyroid from the trachea and from the recurrent laryngeal nerve, and putting another needle here, and the assistant is continuously pushing water. This is the RFA antenna needle, putting it, then doing ablation. After few minutes, less than 2 minutes, the ablation is successfully done. What is the criteria of successful parathyroid ablation? How to know that you did your job and mission well? Number one, and this is the most on-site thing, is to make sure that the vascularity of the gland is disappeared again and again and again. If the vascularity of the parathyroid does not disappear, usually the results will not be satisfactory. Actually, in some specialized centers, they can do the parathyroid within just 30 minutes. Usually we don't have this facility, so usually we measure it on the night sample. But the most important thing is that the vascularity is disappeared, and you are doing a good job if you don't injure the recurrent laryngeal nerve and the patient, there is no hoarseness and there is no injury of the vocal cords. All of us know that the half-life of the parathyroid is just less than 8 minutes. So if you just take a sample of the parathyroid after just 10 minutes or even after a few hours, you will notice that it is successfully and markedly dropped more than 50 to 80% of the initial pre-ablation level. In the next 48 hours, the calcium level will be dropped and the phosphorus will be improved. Then in the next few days and few weeks, the patient's symptoms will be improved. One of the things that I noticed when I'm doing ablation, especially those in elderly, especially those with a heart failure or a cardiovascular risk factors, that with a rapid drop of the BTH, there is a removal of a lot of antihypertensive drugs. A lot of patients developing hypotension if they are taking their own regular antihypertensive drugs. When I started to investigate and read about this, the supraphysiological doses of parathyroid is a very potent stimulant for the renin-angiotensin system. And if you are doing a drop of the parathyroid, subsequently the renin-angiotensin system will be inhibited, so the blood pressure will be dropped. And usually the patient is developing some postural dizziness and postural hypotension, and sometimes may develop arrhythmias. All of this because of rapid drop of the BTH. 100% this will be more and more severe in the surgery, but don't be panic if you notice this in the patient, especially those with a tertiary hyperparathyroidism or elderly, because as I said to you that nowadays the parathyroid and the hyperparathyroidism is not simply a musculoskeletal and renal stones disorders. It is majority of the problems and the comorbidities from the death of the cardiovascular system. So sometimes you notice changes in the blood pressure and the cardiovascular parameters and the arrhythmias develop just after ablation. If you are doing follow-up by years, there will be significant reduction in the volume reduction ratio. Up to some times of cases, the parathyroid itself disappear in the ultrasound, just 2 or 3 millimeter of scars are there. I know that there is a lot of questions for you as a doctor if you are hearing about this topic for the first time, for the patients, for the surgeon, for me. There is a lot of questions are running in your mind now. The first question, what about the other parathyroid gland? Are there any chance to develop adenoma in the other parathyroid gland? The answer is yes. And this chance and this outcome is similar in both surgery and ablation, because the surgeon is usually doing open a small scar and remove this affected lesion or the affected parathyroid in majority of cases of hyperparathyroidism. If he do not have any localization, the expert parathyroid surgeon is doing exploration for the 4 parathyroid glands and try to remove the suspicious one by one, till there is a rapid drop on the BTH. But if I'm doing just removal of one parathyroid gland, there is a genetic predisposition, there is another factors that may have any recurrence for the other 3 or 4 parathyroid glands. So this could be recurrent in the future. The answer is yes. It is similar in surgery and similar in ablation, and you can do ablation again in the future. Number 2, what about the long-term follow-up data? Actually, the long-term follow-up data in the surgery is more than 10 years. We have a long evidence, and we have a solid evidence that the surgery is the gold standard for treatment of cases of hyperparathyroidism. We have a solid data that there is thousands of patients having stability and normalization of the parathyroid after surgery. But because the ablation in the field itself in the parathyroid is just recent, most of the data and the long-term follow-up data is 1 to 2 years maximally and few months, because this is just a recent, but this is one of the issues. I think with time, and I think with experience and with registry and the ablation become more popular, we will have solid data about this. What about the cost effectiveness? I don't know how the situation here now in Bahrain, but in Egypt, we have a lot of expert surgeons, and the cost of surgery is relatively cheaper or similar to the cost of ablation. So this is one of the main concerns in Egypt, that the cost of surgery may be similar or just higher to the cost of ablation, or just lower to the cost of ablation. I don't know how the situation here in Bahrain, but in Europe and USA, the cost of surgery is double or triple the cost of ablation, and also the indirect cost of hospitalization and work absenteeism and quality of life and the scar and follow-up and is in the part and the side with favorable toward the ablation. One of the most also concerned about this, especially from the surgeon, the term of parathyroid mitosis. What's the parathyroid mitosis? The parathyroid gland is a very friable. If you are doing a lot of manipulation inside the parathyroid, some of the parts of the parathyroid gland may disseminate and regrowth again, either extrathyroidal or intrathyroidal. This is called parathyroid mitosis. Actually, this is a theoretical. I have never seen a case of this, and also when I ask my senior surgeon, this is very, 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 very rare. Till now, it is not reported for the literature that the patients who are doing doing thermal ablation for a parathyroid develop seeding of the parathyroid tissue and regrowth again. It is not yet reported in the literature. What about the drop of the PTH and the hungry bone syndrome? If you are an endocrinologist and doing ablation, you can manage this. If you are a surgeon or radiologist or oncologist doing ablation, you should refer for the endocrinologist to make sure that there is a sufficient level of vitamin D, to make sure that the patient is taking calcium immediately after finishing of the ablation, because all of us know with a rapid drop of the parathyroid, all the osteoblasts starting to work up, because they are inhibited from the hyperparathyroidism for a long time, then they will take the calcium from the blood, and there is a cases of severe paresthesia and tetany and muscle cramps if you don't supply and don't replace the vitamin D. The patient should do ablation, even surgery, with a sufficient level of the vitamin D and with a high normal level of the calcium. Finally, is there any guidelines? Till now, if you search in the literature, there is no guidelines. But alhamdulillah, I'm lucky to be one of the chosen from the Middle East. Professor Ming Yu in China and China Japan Hospital, we performed a consensus about the parathyroid, and it is accepted in the International Journal of Hyperthermia. Inshallah, it will be published within the next few weeks, so you can have the guidelines for the hyperparathyroidism. But there is a dozen of literatures and dozens of papers. This is just updated up to December 2025, that report that the thermal ablation for the cases of primary or tertiary hyperparathyroidism, which decline the surgery or contraindication for the surgery, is a very favorable action and very effective. Mr. Chairman, dear colleagues, let me end my presentation by this few take-home message. Nowadays, the world are moving toward the minimally invasive procedures, the interventions, to avoiding the surgery as much as we can. So the thermal ablation for the parathyroid adenomas are a minimally invasive alternative to surgery, expanding the role of endocrine interventions. Number two, the safety and efficacy is proven in a lot of studies and thousands of patients. Number three, the main concern is the cost effectiveness and the long-term follow-up are the main concern. I invite you here to join us with Dr. Hossam and Dr. Ahmed Mordi. They are invited to join us in the third annual conference of the Pan-Arab Society of Intervention Endocrinology and Diabetes Technology. Inshallah, it will be in Alexandria Bibliotheca, one of the iconic places in Egypt. We have pioneers, a lot of doctors, but on top of them, Professor Ralph Del Fronzo and Parathyroid, pioneers in the diabetes, and Professor Beck and Professor Roberto Valcavi will join us, inshallah, physically. So I invite you to join us, Dr. Hossam and Dr. Ahmed Mordi, and all of you are invited. Here's the link of registration if you want to register, and you will find very, very lovely Alexandria city. You will enjoy the place. Also, I invite you all, especially my young colleagues, to be a member in the passage. It is free registration. You can just fill the Google form and become a member. If you be a member, you will be having every 1 week, you have emails with the regular updates and regular studies. You will be freely access to 5 high-level webinars every year. You will have opportunity to attend our workshops, and you will have a professional certificates and membership. Thank you again, Dr. Hossam, for inviting me, and thank you, Mr. Chairman, and happy to hear any questions. Thank you.